Hello, everyone, and welcome again to follow one of our webinars that we've been holding during the pandemic time. And my name is Juho Impivaara. I work in Laerdal as a territory manager. And today, as you can see, we are not in the office as before, but this time we are in Kuopio, and more specific, we are in Kuopio University Hospital and ICU. So intensive care unit is the place for today's webinar. And as you can see in the video, I'm not alone here. So with me, I have our clinical specialist Kirsimarja Metsävainio here as well. So Kirsimarja, would you please introduce yourself to the audience?
Thank you, Juho. Hello, everybody. My name is Kirsimarja Metsävainio. I'm an anesthesiologist, and I work as a clinical educator or a person who is responsible for our simulation education in the Kuopio University Hospital in the Center of Clinical Education. And today we are very happy to present you a case scenario from our intensive care unit educational program for a respiratory distress patient. Our Kuopio University Hospital is one of 5 university hospitals in Finland. We are in the eastern part of Finland, in Kuopio city area, and we have about 600 beds, and the area around our own hospital is about 200,000 people, and the whole area of our which we are responsible is about 700,000 inhabitants. So we have a personnel of 4,000, mainly nurses, and about 800 doctors. And here in our intensive care unit, we have 14 rooms and around 30 beds. And the staff has about 120 nurses, and the doctors who are doing on call here in the ICU are around 30. So we have about 150 persons to educate for a simulation education, and we have had quite many programs for them, like the first hour for the intensive care patient, the child patient in the extubation and intubation protocols, and also which is very interesting because we have a cardiac heart surgery center here in Kuopio. We have doing re-sternotomy training, emergency re-sternotomy training for our personnel, in which we use a Laerdal mannequin which has been opened and modified to make a re-sternotomy for the patient. So we have quite nice setup of simulations, but we could use more, and now we are planning to do simulations which concentrate on the neurological failures, respiratory failure, and also circulatory failure, and doing that kind of thing. And this is one of our respiratory failure cases scenarios, which we are now presenting to you with Juho.
Thank you, Kirsimarja. And before we go that, as it says in the topic, our today's topic is plan, execute, advanced respiratory care simulations, and we will talk about that. And Kirsimarja will tell us about a bit about the planning and the executing, of course, as well. But before we go into that, could you please describe what kind of facilities for simulation training you have here? Since all the audience can see, we are in the patient room now, but what kind of other simulating facilities you have here in Kuopio?
Well, we were the first Finnish university hospital to get its own simulation center. It's in the downstairs in this quite new building, which was built 2015. And we have 2 simulation rooms there with a connecting machine room or operating room, and 3 lecture rooms. It's quite small, but it is sufficient for our needs, but we are doing a lot in situ simulation. So we try to bring the simulation to the real place, like in here in the ICU, or in the emergency room, or in the, for example, in the operating theater. So it is the best to train professionals, in my opinion, to do the simulations in situ, because there, as you can see, the equipment, all the medications we have in the background, which you don't see. There's a medication, automatic medication cabin, which should be used by nurses and other things. This is familiar, and the solutions which Laerdal has been producing, like advanced mannequins, like SimMan, which can be put onto the ventilator and which can be intubated. And now it is in our servo eye ventilator all the time. And also we have been able to put the Laerdal patient monitor to our normal regional monitor with the screen share. So the nurses and doctors can look just right where they usually look. Okay, doesn't look like the normal monitor, but we have also tried the Laerdal solution called Vital Bridge, and it has been working very well in our cardiac care unit. And then in that you can put a real monitor with simulated parameters, and that works quite nicely and helps the personnel to get the feeling of real situation during the simulation.
When evaluating the results of the simulation training, how important do you see that we can use the real equipments in this case and the real environment that we are now?
It is, I think it's very important because the ability, the immersion, it's called immersion into the simulation. It gets better with the real equipment and real environment. So the problem with adults is usually they think we are playing with mannequins. No, we are trying to simulate the reality, the real things that they do in the real life. And when we are in the real environment, it's much better that way.
Yeah, thank you. I think we're ready to move forward to our patient case. But before that, behind me, maybe you can see I have an iPad here for that reason that I will see your comments and answers. So what will we do next? That we will start going through our case that Kirsimarja will go through in a couple of minutes. But please, when we ask questions, what would we do next, or what would you do next? Please write your comments to the chat box, and then we can see your answers from there, and maybe continue the simulations towards the way that you wanted to go. But yeah, so any comments, any questions, please write them in the chat, and we will go through them. And also this whole webinar is recorded, so you will be able to see this afterwards and share it to your colleagues if they're not around today. But yeah, would you please explain a little bit a case and the setup that we're now having here?
Sure. Okay, we have this case. Patient has a adult respiratory distress syndrome, so a very moderate or difficult oxygenation problem. The case scenario goes like this is a 58 years old male person. He has a very difficult bacterial pneumonia and ARDS. He has been on ventilator for 5 days. His weight is 87 kilograms and the height is 181 centimeters. He's intubated and he's on the volume control synchronized mandatory ventilation. I don't know, is this very well seen? Because of the mannequin is an electrical equipment, we are not able to put the FiO2 as we like, so it goes to 21%. And also the PEEP is a little bit lower than it should be. In the beginning, this patient has tidal volume of 510 milliliters. The frequency is 20 per minute, and end expiratory pressure is 8 centimeters water, and the fraction of inspired oxygen, FiO2, is 0.5, it's 50%. The patient is quite hemodynamically stable, although he has a noradrenaline infusion, 8 milliliters per hour. He has a basic fluid going on, 200 milliliters per day perhaps, and he's on antibiotic treatment with piperacillin, tazobactam, and he has a septic shock hydrocortisone going on, which we use 50 milligrams 4 times per day. For sedation, he has a propofol infusion. Now it goes 10 milliliters per hour. And nurses use bolus fentanyl. And sometimes if they need rescue medication, they use midazolam and rocuronium as a muscle relaxant. In the beginning, the patient is stable. He's intubated. The tube depth is 23 centimeters. The oxygen saturation is about 88, 89. Not very good, but it is the required minimum. We are very happy with this situation. And the compliance, the lung compliance is around 30 about, and blood pressure is about 100 over 50, and patient is in the sinus rhythm, and there is a rate of frequency of 115 beats per minute. Patient is sedated with propofol and fentanyl boluses, and it starts to wear off, and the patient starts to breathe more spontaneously. So he wakes a little bit up. So let's see what happens.
I don't know if you can see the monitor really well.
Yeah, the patient starts breathing, and maybe moving a little bit his head, like here. And the problem is that the saturation drops to 81 to 82. So question is for the participants or you in the behind the camera. So what would you do? Would you rise FiO2? 1. Would you rise tidal volume, and how much? Would you change frequency, rise or get it lower? Would you give fentanyl? Would you give midazolam? And would you give rocuronium? And which amount of fentanyl, midazolam, and rocuronium would you give? Now you have a minute or two to answer these questions. So, and I will say them again. So, would you change FiO2, the inspired oxygen? Would you change tidal volume? Would you change frequency? Will you give any medication, fentanyl, midazolam, rocuronium, and how much would you give? This is like some kind of not a competition, but a quiz for you.
Yeah, so please go ahead, write your answer to the chat, and we can continue after that. We will continue anyway, so don't worry. We won't stop here unless we don't get any answers. But
in our simulation scenario, the participants are seeing this situation. They have to adjust. They have to adjust the treatment of the patient according to the situation. So they have to respond to the problem. Are there any?
Not yet.
Suggestions. What would you do? Okay.
Okay, I think we're ready to move on.
Okay. So first thing.
Hey, well, let's wait a bit. We got our first brave here, and she's saying that change FiO2.
Okay.
But happy that I'm not treating the patient since I'm not specialist. Just one curious attender who is joined to our webinar.
Okay, I will change the FiO2 was in the beginning it was 0. It was 50%. 50%. So I would change it to maybe to 60 or 70% from here. And because the patient is breathing, he's doing a lot of breathing work. He's restless. I would give him sedation, fentanyl, 50 micrograms from the beginning, maybe midazolam 1 milligram, and see what effect that has. Does it calm down? And with these medications and the FiO2 rise up, the patient calms down. The spontaneous breathing goes away. He's again very calm. But we have a problem with oxygenation. The saturation is not going up. So what's the problem? We ask from our participants. What is the problem? Why is the oxygen going down? And now we can have a discussion about oxygenation problems, like the shunt which is behind all this. So what is the reason of the oxygenation problem? And what would you do if you have this kind of problem? It is important always check if the delivery system is okay. Is the tube on the place? Is the cuff filled, or the cuff pressure? Is it? We are measuring cuff pressure continuously, not in this simulation, but usually on the normal patient. So if it's okay, is there any problems somewhere else? And then the first thing to go after the sedation is okay would be to change the ventilator settings. So how would you do? What would you do next? Would you change tidal volume? Would you change frequency? Would you change positive and expiratory pressure, PEEP? And how much? And remember, we are on the volume control. We are on the volume control mode with the SIM, so spontaneous mandatory ventilation. And the peak pressure is going up to 35 now in our simulation. So also the plateau pressure is getting very high, and you might remember that the recommended plateau pressure should be around 28 or not exceed 30.
Yeah, there's a couple of comments, and also give some midazolam. So that was probably for the first question, which is correct. And then there's a question: how much is the PEEP now?
The PEEP in the patient is right now it's 8. How many fingers? 8. So what would you change in the ventilator settings? In our ICU, the nurses are doing lots of adjustment of ventilators, and they are. But this kind of situation, they might ask the doctor, and we have lots of young residents who are very familiar in the operating theater, but not so familiar with the ICU patients.
Should we go through at this point that what have we done so far? Yeah. So basically, the situation from the beginning, it hasn't changed much. The saturation, it's going low, low still, and What's the clinical status of the patient now?
Blood pressure is also a little bit lower, but we gave him sedation, propofol, midazolam, fentanyl, and so on. What is important is to check for the participants, to check the clinical status for the breathing. So do always your ABCDs. That is very important because the clinical examination and the lung auscultation is a very important part of the taking care of the respiratory distress patients. So you can hear if there are new atelectasis or if there might be pneumothorax. And also an ultrasound on the bedside is important to do rehearse so that young resident, young doctor can start and learn problem solving skills. So what he should do, check the auscultation, maybe check the lung ultrasound and so on, and then change the settings of the ventilator.
Yeah.
So any suggestions from the chat?
Yeah, there's a question that what will happen if you increase PPV?
What is the
PPV?
What is not so familiar with that?
Yeah, could you please for pressure? There's a comment that it means pressure
increase. We are not using Finland that kind of
short sentences. Yeah.
I might understand you if you said it in English.
But you were mentioning about the APCD protocol during the treatment of the patient. So how often would you recommend to do that? Like the frequencies of doing your APCD?
Well, our nurses are doing this one time per hour, but doctors usually once or twice per their shift, depending on.
Yeah.
I only understand per PPV and positive pressure ventilation, so I'm not sure. The first thing to use when the oxidation goes lower is to increase the positive and expiratory pressure. So we open the alveolus. I would increase the PEEP from 8 to 10 or 12, or maybe you shouldn't fix on the even numbers, so maybe 1 or 11 or 13, whatever makes any difference there. Another thing is the tidal volume also. But we need to remember that when we are treating the respiratory distress patients, so the recommended tidal volume is 6 to 8 milliliters per kilogram. So don't exceed that. But a small increase in tidal volume might recruit more lungs for the delivery of oxygen to the patient. So we try to recruit the lung in the situation when the saturation falls down. Of course, to the clinical examination, we might use also the arterial blood gas sample. And we have any answers or results for, we can give the to participants, say, results from arterial blood gas if they like to check it out. And also a setup for X-rays, if they need to take a thorax X-ray or like to take it, we have prepared for the simulation a setup for thorax X-rays. And of course, we have a CT scan for in the beginning, how does the lung look like?
Yeah, we have a comment that good answer for unclear questions. So thank you, Kirsimarja, for that. Okay, what would be the next step?
Okay, we increase a little bit of tidal volume, maybe maximum 50 milliliters. It depends how do you like to do it, how do you look at small steps. I recommend the more critical patient, the smaller the steps. So don't make big moves. Make a small moves and check it, wait out what happens. Because when you increase the tidal volume and when you increase the PEEP, you affect the intrathoracal pressure, and when you affect intrathoracal pressure, you affect the heart, because a heart-lung interaction is utmost importance, and the heart and lung ultrasound has evolved in last about 10 years as a very important tool for ICU patients. And we don't have such a mannequin where you can really do the ultrasound examination during the simulation, but I would like to have some that kind of mannequin that you can do and learn from the ultrasound results and to go on with that within simulation. Well, next, the problem is that when we have increased the PEEP and when we have increased the tidal volume, and maybe if we didn't give relaxation with rocurone, muscle relaxant, we might think about it now when the saturation, it might fall even more lower, around less than 80, if we should use muscle relaxants and try to really calm the patient down. As we know, the prolonged sedation and muscular relaxation are risk factors for critical neuropathy, critical care neuropathy and polyneuropathy. So it's very going up and down with these choices and decisions we make. But now we have a very high airway pressure. It goes around 40, and the plateau pressure, which can be measured, we use it with this servo, and I think it's available in other ventilators. Any modern ICU ventilator, you can measure the plateau pressure. It's now 32, so it's too high. The lungs are distended, they are over distended, and that might be a problem. It hurts or makes more inflammation in the lungs, and the problem is that you might have a barotrauma or a volutrauma to the lungs. So the treatment we give to patients is harming the lungs. Well, what should you do now? There is a high plateau pressure, high peak pressure, and the oxygenation is still lagging around 80, 81. Not looking very nice. We can still rise the fraction of inspired oxygen. It is only now 80, and you can think about if you can rise it up to 100%, but then it's over. You can't give any more. Should we try to reduce the tidal volume? And should we try to reduce or rise actually the frequency? Lower tidal volume, higher frequency. We still have to eliminate the carbon dioxide from the patient. But it has been established that the so-called permissive hypercapnia is not dangerous. The patient can adapt to higher carbon dioxide levels if the rise is steady and slow. Well, we have been doing a volume control. How many of you would like to change suppressor control? Is there any answers?
Not yet, so please go ahead and use the chat again and write your answer there, and then we will see what happened next to the patient.
Would you like to change the ventilation mode from volume control to pressure control? And we have also possibility to do pressure regulated volume control in this servo ventilator.
Yeah, the vitals at the moment are a heart rate 112, saturation roughly 80, 82, 83. Arterial pressure is 90, 92 over 40, 43. And the capnograph is 4.5 at the moment.
It might get a little bit up because of the the problem of elimination of carbon dioxide.
Yeah, and the respiratory rate is 20.
Mm.
Yeah, 20. Okay, I
Any
think we
ideas?
not yet any ideas. So lots of thinking going on behind the camera, but
Well,
go ahead.
well, at least if we haven't been giving a muscle relaxant like rocuronium, which we use, you can use others, of course. I would give it right now because we have a problem with the high peak pressure. We should relax the patient. He doesn't resist the ventilation, and I would change the ventilation mode to the pressure regulated volume control. It is important to participants who are nurses and doctors in the ICU to understand the difference between these ventilation modes. It is very important that the volume control delivers volume. And it is you can be sure about the minute ventilation in the volume control. Tidal volume multiplied with frequency is what you get. With pressure control, you deliver pressure, and the tidal volume depends on the lung, the quality of the lung tissue. So, and the quality of the respiratory problem. So the pressure doesn't get up, so it doesn't hurt the lungs, but the tidal volume changes with time. So you have to be very careful that the patient is not underventilated. So the tidal volume goes down, down, down. Frequency is the same, so the carbon dioxide gets up, up, up. So, but the pressure regulated volume control is volume control, but which is pressure regulated. So there's volume and there is pressure limits. So it protects lungs maybe better. There are no good evidence about which mode, volume control or pressure control, is better, but it depends what you are familiar with and what you are used to do. So there are questions.
Yes, comment that we should change to pressure volume control and relax the patient.
Yeah, I agree totally. Yeah.
Okay, should we do that?
Yeah, we should do that. Ticks. I have to change from here and put the settings very well, and that is what our participants would do themselves with the mannequin and the ventilator, so they can fix it up the way they like to do. And then we could discuss about the settings and how they would how the patient would react to this situation. One question which I always ask from participants is that should we turn the patient into the prone position? Now, this patient is not COVID-19. Oh, he could be, but we don't have the suits and so on. Sorry. During the pandemic and COVID-19, the prone position has been the rescue method for many patients. And in our own ICU, we have treated about only 30 COVID patients in Finland. The COVID-19 has been very calm, but we have had some patients, and one or two in ECMO, and lots of them in prone position. And we have been rehearsing through simulation, turning the patient into prone position. And that has been a very good simulation too, because you have to remember certain points and safety points, and so to get the good things out of the prone positioning.
Yeah, and after the recommendations that we got from our attendee, we can see a little bit improving on the
Yeah.
vitals here. So the heart rate has increased or decreased around 90. The saturation is roughly 90 as well. No significant changes in blood pressure, and capnograph it's about the same, so
Yeah.
5.2 at the moment.
Yeah, I would take now an arterial blood gas sample
Yeah.
and check it out, the vitals, how is the oxygenation, how is the pH, what has happened to carbon dioxide, how is the patient faring, and do the airway breathing circulation just evaluation again to see that this is okay. Then I can go to coffee after the treatment, after this difficult case.
If we think about, we go a little bit back and we think about the planning the simulations. You mentioned about the thorax pictures, for example. So would you be preparing to display some ultrasound pictures for the participant here, or EKG, or
Yeah,
what kind of more information would you provide?
I would do that. I know that the Laerdal simulation system it is able to go and see there, but that's not the normal way. We can't see them on the monitor. So I would set up a laptop computer with these findings, because when doctors ask for example, thorax X-ray, there becomes the radiology department nurses. It takes time. It takes they take the picture and then you go somewhere to see it. So I would make this situation as real as possible. So the doctor goes and then he has to tell the team what are the findings. So that is also the treatment of the intensive care unit patient is teamwork. Yeah. And one of the main objects of our simulation training is enhance the teamwork.
Yeah.
And I think that is very important when we're treating critical ill patients.
Talking about realism and immersive, so do you like to take the real time that goes to that in the real situation as well? I mean that taking an X-ray, it takes what, 10 to 15 minutes at least. So do you like to use the time as it is in the real life, or make it faster, or what's your opinion on that?
Yeah. Well, if we have, for example, we don't have radiology department nurses here. So if they want to take an X-ray, we have something simulated background, for example, a plastic. What it is, the nurses need to lift the patient safely. Our beds are not that you can put the cassette under, so they have to lift it and put it under the patient. So they have to do it as a team. They have to do it, prepare safely, because the loss of the tube in this kind of patient is catastrophe. So that is a very important thing, that you use, make ICU procedures safely. And then when they have done it safely, the doctor gets the picture and can interpret it and tell the results to the team.
Yeah. Okay. What next? What are the next steps?
Well, our patient is feeling quite well, so we go to the coffee. So everything, we enter scenario. As you can see, this was three steps, different steps, and you can also drive it on all the time. So you can have the learning discussion or debriefing after the sets, but you can also stop after every step, so-called rapid cycle education. So you can discuss what you should do and why did you do like that, and what should you do really, and then go forward, like in a way we did now.
Yeah. This kind of simulation that we have been now going through pretty well here. What kind of target group would you recommend it this, and what would be the what kind of knowledge do the participant needs to have before taking apart a simulation like this, as it is like advanced simulation? So I assume this can't be the really first simulation that they are attending, or do you disagree on that?
Well, when the nurses and doctors they come to work here in the intensive care unit, they are treating patients like this.
Yeah.
So if you are doing a simulation in Finland, I don't know how it's in other Nordic countries, but in Finland we try. Usually, our educational system is just throw the patient into work, the person into the work. So if we are running this kind of simulation, it is a huge step up from that you have to go and think yourself, what shall I do, and ask the seniors or whatever. So when you can train the residents and the young nurses or fresh nurses with this kind of simulation, they can safely learn and discuss about the problems, not in the middle of the night when they have this kind of patient in their hands.
Yeah.
That's our main object, to establish this kind of training. And I think, and if you have in your own units this kind of training, please write into the chat and tell us the ideas what you are doing and what you have been training and rehearsing.
During the pandemic, did you have a need of familiarizing a new staff to the ICU?
Yes, we did. Yeah.
Did you use simulation to do that, or
Yeah.
do you know how it was executed?
Yeah, we had this prone position turnarounds, and then we had this operating theater nurses getting working in the ICU, and we had some e-learning material which they could use. But in Finland, we were prepared for this kind of a pandemic catastrophe, and it didn't come. So we changed back into a normal system, and it has been quite enough, and we haven't needed the extra stuff from the operating theater. I think only in Helsinki they have had this specialized COVID-19 ICU working in the different place, not in here in Kuopio.
Yeah. Thank you. Do you have anything to add when it comes to treatment of the patient, or if we look at the topic that we were going through, so planning and executing advanced respiratory simulations? Do you have, Kirsimarja, anything you want to still add to the audience?
Well, I think that running simulation is a complete fun, and I think I enjoy every time. And doing this kind of simulation and trying to stimulate the participants to think and to learn, and maybe sometimes preparing and reading and learning beforehand and afterwards about this. Yeah, I think that's the makes my day.
Yeah. Okay, we have still a couple of minutes left, so please use the time and write your comments, write your questions to the chat. So we have still a couple of minutes to answer those questions. And then while you guys are doing that, I think I know this was the last webinar before summer. Now summer is pretty close, and we will obviously continue doing these webinars when the fall comes. And you can also access some ideas or topics that you would like to hear, and we will make it happen then in the fall. But I don't see any questions here, so I think we are ready with our webinar today. And on behalf of Laerdal, thank you, Kirsimarja, that we could be here and you could be with us here, and we could actually use the real environment here and make it a little bit more realistic and maybe even immersive to the audience as well. So this was our webinar today. I want to thank you all, and thank you, Kirsimarja, for being with us.
Thank you. It was a real pleasure, and I really hope you enjoyed our small talk about this simulation in the intensive care unit.
Thank you. And you will get a recording afterwards, and you can share it that to your colleagues. So thank you, everyone, and bye-bye.
Bye-bye.